Hey, so today I want to talk about psoriasis. Now I know what you're thinking. Psoriasis? Really? Everyone knows psoriasis. But hear me out. I'm a pathologist with dermatopathology expertise, which means psoriasis biopsies land on my desk pretty much every day. And over time, you start seeing this disease very differently when you have looked at it under the microscope hundreds of times. So what I want to do today is just talk about it casually, the clinical picture, what's happening underneath, and why the two make such perfect sense together. What does psoriasis look like? Sharp, well demarcated, scaly plaques, silvery white scale, erythematous base. The classic sites: elbow, knees, scalp, lower back, and nails. That word, sharply demarcated, is very important, by the way. The edge is clean. There is a very clear boundary between involved and uninvolved skin. Now, there are three clinical signs I genuinely love. The first is the auspitz sign. You lift the scale off a plaque and you get pinpoint bleeding. Little droplets, very characteristic. The reason this happens is because the blood vessels in psoriatic skin are sitting right under a very thin layer of epidermis. So when you remove that scale, you're almost directly exposing those vessels. The second is Koebner phenomenon. Psoriatic lesions appear at sites of skin injury, a scratch, a scar, a sunburn. The skin gets injured and responds with psoriasis. Koebner described this in 1879. The third, and this one most people don't mention, is Voronov's ring, a pale blanching ring that sometimes appears around the psoriatic plaques. It's subtle. You have to look for it, but it's a real sign of local vascular reactivity in the skin surrounding active disease, the pathogenesis. Okay, so I'm not going to do a deep immunology dive here, but I need to give you just a little bit of context because it directly explains the histology. Psoriasis is immune mediated. T cells, T helper 17 mainly, are releasing cytokines interleukin 17, interleukin 22, and tumor necrosis factor, and these are essentially screaming at the keratinocytes to proliferate fast. Normally, keratinocytes take about 28 days to travel from the basal layer to the surface. In psoriasis, that's compressed to around 4 days. These cells are being rushed out before they are ready, before they have matured properly. And when you look at the biopsy, you can see exactly that happening. Histopathology. Right. This is my part. But I'll do a detailed video later on. This will be just brushing through. When a psoriasis biopsy comes to me, there is a specific set of changes I look for. And interestingly, the histology changes depending on what stage the lesion is in. Early lesion, tiny pinhead papule. Honestly, not very satisfying to look at. It's not diagnostic at this stage. There will be mild acanthosis, perivascular lymphocytes, dilated capillaries, a bit of papillary edema. The keratinocytes look slightly swollen. No neutrophils yet. If this came to me without clinical information, I probably wouldn't call it psoriasis confidently. Active lesion. Now we are talking. The advancing edge of a plaque or a gutted lesion, that is diagnostic. In the dermis, the capillaries are increased, elongated, and tortuous. Edema is seen at the tips of papillae. Mixed infiltrates with lymphocytes, histiocytes, and now neutrophils. And in the epidermis, two findings that are essentially pathognomonic: the spongiform pustule of Kogoch and the microabscess of Monroe. In these areas, the granular layer is absent or very much diminished, hypogranulosis, because the cells were pushed out before they could form it. And parakeratosis is seen throughout. What is that? Nuclei still present in cells that should have lost them by now. Rushed, immature. Exactly what you would expect from the cells that had 4 days instead of 28. Now, coming to stable lesion, the chronic plaque. The red ridges are now elongated with a very characteristic squared off appearance, like test tubes. Dermal papillae are elongated and club shaped, and at the tip of each papillae there is only a very thin plate of epidermis covering it. The spongiform pustule of Kogoch. Basically, neutrophils collecting in the upper spinous layer. within a spongiotic area. The keratinocytes around them look loose, almost like a sponge, and neutrophils are sitting in those spaces. It has a very particular look. Once you have seen it, you don't forget it. Microabscess of Monro. Higher up, the neutrophils and neutrophil debris in the stratum corneum are surrounded by parakeratosis, and this is called the microabscess of Monro. Together, these two, psoriasis until proven otherwise, except that you have to always rule out fungal elements by doing a fungal stain, that is a PAS or a GMS stain. Let us just connect the dots quickly. That silvery scale clinically, that is the parakeratosis, nucleated immature cells piling up on the surface. The red and the warmth, that is the dilated tortuous vessels, angiogenesis, and inflammation. The thickness of the plaque is the epidermal acanthosis, the elongated rete ridges, a whole epidermis in overdrive. The sharp demarcation, involved skin is biologically completely different from the uninvolved skin right next to it at that edge. Auspitz sign, because of the thin suprapapillary plate, those elongated vessels in the papillary dermis are just one scratch away. So that's psoriasis from where I sit. I'm a pathologist learning the clinical side. And honestly, studying it this way, connecting what the dermatologist sees to what I see, makes it much more interesting than just reading either side in isolation. If you enjoyed this, give a like and subscribe. See you next time. And I promise you, I'll be coming up with a detailed histological explanation on psoriasis. But that will be some other time. Bye. Take care.